Here we'll learn about thyroid tumors with epithelial origins. We'll use terminology from the 2017 WHO classification scheme. To begin, start a table and denote that thyroid tumors can be benign. These are called adenomas, or malignant. These are called carcinomas. As we'll see, we use capsular and vascular invasion as key indicators of malignancy. To note that thyroid cancer is the most common endocrine cancer and is in the top 10 of all cancers. Thyroid tumors are more common in women over 40 years old. The majority of thyroid tumors are sporadic, but to note that key risk factors include pre-existing thyroid disease and or goiter, but be aware that not all studies support this association. Exposure to radiation, including X-rays and gamma rays, and iodine deficiency, although an important exception to this is papillary thyroid cancer, which is associated with too much iodine. Early and late driver mutations are also predictive of thyroid cancer and helps us link precursor tumors, adenomas, with progression to specific carcinomas. We'll call out key genetic associations as we learn about the different tumor types, but see the link in our notes for more information. Because thyroid tumors more often appear in women, a hormonal association is expected, but is yet to be verified. In cases of suspected malignancy or other complications, tumor removal is recommended. The need for additional treatment, such as radiation, depends on the malignancy. Before we learn about tumor types, let's show the anatomy of the thyroid gland to better understand key signs and symptoms that tumors can cause. Draw the head and neck in lateral view, then show the esophagus with the larynx and trachea anteriorly. Show that the lobes of the thyroid gland wrap around the trachea. When large enough, thyroid tumors can compress these structures and the associated nerves and vessels and cause hoarseness and difficulty breathing and swallowing. Now let's begin our main diagram with thyroid tumors of follicular cell origins. We draw some thyroid follicles with colloid to remember that follicular cells make up the bulk of the gland and make thyroid hormone. We'll start with benign tumors, which are non-invasive. First, indicate that follicular thyroid adenomas comprise a thin to medium thickness capsule with potentially visible blood vessels. The architectural pattern of the thyroid follicles can vary, but will show the microfollicular pattern. This is sometimes called the fetal pattern because it resembles the follicular architecture of the fetal thyroid gland. We'll show that the follicles surround small pools of colloid. See the link in our notes for more examples of follicular adenoma architecture, including solid, normal follicular, and macrofollicular. Note that a single tumor may comprise multiple areas with different architectural types. Then indicate that follicular adenomas are associated with point mutations in RAS genes. Adenomas are also associated with PTEN, hamartoma tumor syndrome, which results from germline mutations in the PTEN tumor suppressor gene. Rarely, follicular adenomas are hyperproductive or toxic and produce high levels of thyroid hormone. Review hyperthyroidism via the links in our notes. Although follicular adenomas are benign, genetic associations tell us that they are likely precursors for follicular thyroid carcinomas. Next, indicate that Herthal cell adenomas are similar to follicular adenomas, but comprise 75% or more oncocytic cells. Show that the oncocytic cells of Herthal cell adenomas are polygonal with eosinophilic granular cytoplasm due to a large number of accumulated mitochondria. They have dark, centrally located nuclei with prominent nucleoli. Other morphological features, capsule, architectural variants, etc., are similar to follicular adenomas. See the link in our notes for more information. Key genetic associations include RAS and EIF1AX point mutations and a high number of somatic copy number alterations. Lastly, indicate that Herthal cell adenomas are likely precursors to Herthal cell carcinomas. We learn about these towards the end. Next, let's learn about some borderline thyroid tumors between adenomas and carcinomas. First, indicate that NIFTP, non-invasive follicular neoplasm with papillary-like nuclear features, is a category created in 2017 to include tumors that have a low potential for malignancy, despite having features associated with papillary thyroid carcinoma. We can put a tumor in this classification if it's encapsulated or has clear demarcation, a follicular growth pattern, and has nuclear features of papillary carcinoma. These features can be broken down into three categories: enlarged, elongated nuclei that appear jumbled or otherwise crowded, nuclear membrane with irregularities, including irregular contours, grooves, or pseudo-inclusions. These look like clear bubbles. Chromatin clearing with margination. This makes the nuclei look glassy. Indicate that RAS point mutations in PPARG and THADA gene fusions are associated with this class of tumor. Some authors argue that these genetic associations make this class a likely precursor for the follicular variant of papillary thyroid carcinoma. Then indicate two more borderline thyroid tumors: follicular tumor of uncertain malignant potential and well-differentiated tumor of uncertain malignant potential. And these categories are associated with uncertain invasiveness and therefore give little direction for treatment strategy. Thus, some authors argue that we should avoid this terminology and instead strive to determine the invasiveness and nuclear features scoring in all tumors. Lastly, in this borderline group, indicate that hyalinizing trabecular thyroid tumor is indolent but has papillary thyroid carcinoma nuclear features. It is rare. Now let's turn our attention to malignant thyroid tumors. By definition, these tumors are invasive. We'll start with papillary thyroid carcinoma because it accounts for 85% of all thyroid cancers. Indicate that these tumors are characterized by finger-like projections of branching papillae comprised of a fibrovascular core and epithelial covering. Show the papillary nuclear features like we drew in NIFTP: large jumbled nuclei, irregular nuclear membranes, nuclear grooves, nuclear pseudo-inclusions, and chromatin clearing, sometimes called orphan annii. Additionally, show some bodies between the papillae. These purple-black glassy swirls are unique to papillary thyroid carcinoma and are thought to reflect layers of calcium deposited around a small group of necrotic tumor cells. Be aware that pseudo-samoma bodies may be seen in follicular and Herthal cell adenomas, but these will be visible within the follicles, which is a sign that we're dealing with a fake-out. Lastly, show that tumor fibrosis is common. Indicate that papillary thyroid carcinoma is associated with point mutations in BRAF and RAS genes. We'll see classic follicular and other variants in the cell architecture. Let the nuclear features, samoma bodies, irregular tumor border, and genetics guide you in your designation of papillary thyroid carcinoma. Write that these tumors grow slowly and spread in the lymph with metastasis to nearby lymph nodes. Next, indicate that follicular thyroid carcinoma is the second most common thyroid cancer. It accounts for approximately 10% of all cases. The presence of capsular or vascular invasiveness is key to separating follicular adenomas from carcinomas. Their cell architecture is otherwise very similar. Show that we can broadly categorize these carcinomas by degree of invasiveness. Minimally invasive tumors will fully penetrate the capsule. Look for various shapes, including mushroom and hooks of follicular cells growing into the capsule. Encapsulated angioinvasive means that blood vessels have been invaded. Look for a vessel in the capsule or just outside of it, and be sure that the invaded vessel is lined by endothelium. The tumor itself will be attached to the vessel wall and or covered by a layer of endothelial cells. Lastly, widely invasive follicular thyroid carcinoma comprises non-encapsulated tumors that extend into the thyroid and even extrathyroidal tissues. These tumors do not have papillary nuclear features. They're associated with multiple point mutations, which we list in our notes, and the PTEN hamartoma tumor syndrome. Indicate that they spread in the blood vessels and are prone to metastasis in the lungs and bone. Next, indicate that Herthal cell carcinomas are similar to follicular thyroid carcinomas, but with at least 75% oncocytic cells. We measure tumor invasiveness like we do with follicular carcinomas, and these tumors also spread in the blood vessels. However, Herthal cell carcinomas are thought to be more aggressive, with more metastasis to the lungs, lymph, and bones. Although more common in women, males seem to have a worse prognosis. lastly indicate that these tumors are associated with a high number of somatic mutations in mitochondrial DNA. The carcinomas we've learned so far are well differentiated. That is, they look similar to normal thyroid cells and tend to grow slowly. Indicate that poorly differentiated thyroid tumors represent the next step on a continuum. These rare tumors can arise via de-differentiation of other tumors or de novo. It's thought that mutations in TP53 or TERT are later driver mutations that fuel de-differentiation. Cell architecture varies. Here we'll show the insular pattern in which nests of cells are separated by interweaving fibrovascular stroma. See the link in our notes for more patterns. We show that the nuclei vary and can be small and round or elongated or even convoluted. Tumor necrosis and high mitotic activity are common. These tumors are aggressive and often extend beyond the thyroid. Vascular invasion and metastasis to local lymph nodes or distant sites is common. Tumors may comprise both well-differentiated tissue and poorly differentiated tissue. Lastly, indicate that anaplastic or undifferentiated thyroid cancer completes the continuum. This is a rare but highly aggressive form with a 90% mortality rate. Mortality is highest in poor areas, in part due to delayed diagnosis of well-differentiated precursor cancers. Masses grow quickly and invade local tissues of the neck and throat in most patients, with metastasis to the lungs, brain, and bones. We show spindle-shaped cells invading these organs because many anaplastic thyroid tumors appear this way. See the link in our notes for more images. Be aware that tumors may present with areas of well, poorly, and undifferentiated tissue. Women 60 years and older are most commonly affected. Like poorly differentiated carcinoma, anaplastic carcinoma is associated with mutations in TP53 and TERT genes. They are also associated with a high number of somatic copy alterations. Before we conclude, let's quickly review another type of thyroid tumor that's derived from epithelial cells, medullary carcinoma. First, indicate that these tumors arise from the C cells, also known as the parafollicular cells, which are neuroendocrine cells that lie outside of the thyroid follicles. Medullary carcinoma is rare, but we can recognize it by the nests of cells with salt and pepper or stippled chromatin. These small groups of cells are surrounded by fibrovascular stroma, and amyloid deposits are commonly seen. Be aware that architectural patterns vary. We've shown round here, but see the links in our notes for other shapes and arrangements. Write that, like the follicular cell origin tumors, medullary carcinoma is often sporadic, but inherited forms are associated with MEN2A and MEN2B syndromes, and with germline RET mutations. Indicate that C-cell hyperplasia is a precursor and that calcitonin levels may be elevated. Medullary carcinoma spreads via lymphatic and vascular routes. Metastasis to the lymph nodes is common, and the lungs, liver, bone, and brain are the most common sites of distant metastasis. This concludes our diagram.